Sorry, Bryn, I meant. Okay, let's kick off. Good evening and welcome to everybody. It's a great pleasure to see you. Thank you so much for joining us for our fourth RCGP Together Live panel event. I think we're in for a really interesting and exciting evening. I think you're going to have great fun. So as I say, thank you so much for joining us. We're going to be looking at relationship-based medicine. It's an interesting subject area. It's both fundamentally important for our specialty of general practice. And it's also a slightly slippery concept in which some people aren't quite sure what it means. Probably most GPs are. Some patients get a little bit confused. Some policymakers don't quite get it. So we're going to be talking about what we mean by relationship-based care, but we're also going to be having some substantive conversations about how to deliver it and how to deliver it well. My name is Martin Marshall. I'm chair of the college and I'm a GP in Newham in East London. We've got a superb panel for you today and they'll be introducing themselves in a few minutes. The RCGP Together live series enables us to engage our members with things that are happening in the college, things that are a priority for us in the college, and relationship-based care is certainly one of our three top priorities and has been since I became chair at the end of last year. I think all GPs will recognise the importance of relationship-based care, and there's lots of evidence that having a trusting relationship with a patient delivers a whole range of benefits, including better outcomes for the patients themselves, higher patient satisfaction, greater disclosure of problems that patients might have, greater adherence to medication, for example, reduced access to emergency departments and hospitals, even reduced mortality if you believe that, and possibly equally importantly, higher satisfaction for GPs themselves. So there's lots of evidence that it's important. And I've often said that if relationships were a drug, NICE would mandate us using them. But unfortunately, they're not a drug. And so NICE doesn't. And if anything, I would say that the importance of relationships in some ways is lost on many people, particularly on policymakers who often see general practice as being a transactional set of activities. I've got a chest infection, I need an antibiotic, here it is, and that's it, a kind of one-off interaction. But we, of course, all believe that relationships are an important part of the toolkit that we use as GPs. But there are many threats to relationship-based care, and that's one of the reasons why we wanted to make it a priority as a college. Some of those threats are social threats. Patients aren't as stable in communities they used to be. You have a much faster turnover. In my practice in East London, 40% turnover every year. Doctors often will work part-time, often won't stay in practices necessarily for very long, certainly not for their whole career as they used to. So in a range of ways, the ability to really get to know patients in some ways is damaged. And that's one of the issues that we want to discuss. How do we deliver relationship-based care in quite a different environment from the one that we were operating in 10 or 20 or 30 years ago? We're going to be discussing a range of relevant issues. We're going to be looking at what we mean by the term. We're going to be looking at its core elements. We're going to be looking at the evidence. We're going to look at how to deliver it at a time of social change, how to deliver it in a much more tech-enabled environment, and many other questions as well. There'll be plenty of opportunities for you, the audience, to ask questions. So please do so. You can do so either through hashtag RCGP Live Together on social media or on our online members forum. So there's a range of different ways in which you can do that. So let me move straight onto the panel and introduce them to you. And I'd like to start off with Owen Richards. Owen.
Thanks, Martin. My name's Owen Richards. I chair the college's Patient and Carer Partnership Group. I've got a background as a director of commissioning in the health service, including primary care, and I'm now running a local health watch. And I'm really pleased to be here because I'm interested in that whole issue of the relationship between the clinician and the patient and how that could possibly change from what it's been over the last sort of 70 odd and longer years to one which perhaps reflects some of the relationships now that we're seeing with other professionals in the community.
Thank you very much indeed, Owen. And let's move on to Jen.
Hi, my name is Jennifer Voorhees. I'm a GP in Tameside in Greater Manchester, and I've just finished my PhD at the University of Manchester, which was about understanding access to general practice in the UK. I'm originally from the US, so trained as a family and community doctor, and I speak from my experience as a researcher and as a healthcare provider in both of those systems. And I'm interested in relationship-based care because it very much resonates with the concept of access that I advanced within my PhD, which was called people-centered access, and really focuses on that fit between the humans on both sides of the interaction, on the healthcare service side as well as on the patient and population side.
Great, Jen, thank you very much indeed, and congratulations on your PhD, of course.
Thank you.
Gwyn.
Hello, my name's Gwen Elias. I'm a GP in Leeds and I am the College Person-Centred Care Role for the North Eastern Yorkshire. I also have a leadership role in mental health commissioning in Leeds, and I'm really pleased to be here tonight because I believe that the relationship that we have as doctors with our patients is really important, and I'm curious about how this will be in the future and how we can build relationships very quickly.
Brilliant. Thank you very much indeed, Gwyn. Mohan.
Hi everyone, I'm Mohan Seekar. I'm a GP in Merton. I'm also the clinical lead for social prescribing for Merton and Wandsworth boroughs, which are in South West London. I'm also the person-centred lead, region lead for the Royal College for London as well. And I'm interested in today in also seeing how the relationship interacts between the GP and the clinician, the patient in front of us, but also the community outside and how those relationships can really help amalgamate and also align with the journey of an individual. Thank you.
Tremendous. Thank you very much indeed, Mohan. And finally, Graham.
Hello, good evening, everybody. I'm Graham Kramer. I'm a freelance GP in Scotland, currently in a very wet but very beautiful Ullapool, which is on the northwest coast of Scotland. My role is I'm clinical lead in Scotland for something called Scotland's House of Care programme, which is really concerned with spreading the adoption and sustaining care and support planning approaches, which are collaborative relationship building with people with long-term conditions so that they can be in the driving seat of their care. So we're trying to promote that across Scotland. I'm also an executive officer with RGP Scotland with the responsibility to the patient participation group P3.
Wonderful, Graham. Thank you very much indeed. And I assume that being in Ullapool, you don't want to know that in London it's 28 degrees and blue sky, do you? But I'm sure you don't. I'm sure you don't.
Ow.
Okay, so we have a superb panel, a really well-informed panel with some people coming from a patient perspective, some a clinical perspective, some a more academic perspective. So I think we're going to get a really good discussion. Please do submit your questions in the way that I've suggested, and we will pick them up as we go along. I'd like to kick off with a kind of general question, and I'm going to go to Jen first, if I may, and that's the term relationship-based care. Is it a good term?
Thanks, Martin. Is it a good one? Terms are always hard to choose, I think. I think it is a good one, but I think there's many uses of these different terms, and we need to make sure that terms are understood by those who we're intending to reach with them. I think one of the things that you mentioned it's trying to promote is a trusting relationship between two individuals, and in that sense it's a good term. I think in general practice we should strive to create that for every individual within our population if possible. That includes the people who are calling up and asking for our care, and that also includes the people who are maybe out there in the community who don't reach out for care but possibly have some of the most needs. So I think it's a good term to guide us to think, who do we have relationships with, who don't we have relationships with? And as you said, continuity is a challenge in our current environment. My PhD was about access, and I think the priority of access and lots of policies around access to general practice over years have very much favored a simple definition of timely access to general practice at the expense of broader definitions of access, which deal more with that fit between the health services and the needs of the population. And some of those broader definitions of access very much include continuity of care. So continuity of care makes relationship-based care a bit easier because that relationship is there and it's able to be a continuous relationship. But continuity of care has a few different assets, and I think it talks about relational continuity, which is kind of that based on the relationship between the clinician and the patient. And we know that that's very useful. There's also the other aspects of continuity of care, including informational continuity. And I think what we need to get across to patients each time is that whether we know them or not, you know, I'm a person, I'm here for you. I know that I've not met you before, or I have met you before, and you remind them that either you know them as a person or you care about them as a person, and that's sort of first and foremost. And you can establish that really with almost every contact with a patient, including some of the outreach that I think we need to do a bit more of in general practice in this country.
That's really helpful. Thank you. Owen, from a patient perspective, do patients engage with the term relationship-based care?
I'm not entirely sure that they do. I think you could possibly look at age segmentation. So you might get some older patients who would do that, particularly the ones who will remember that phrase about cradle to grave. But I think, and it almost comes back to the earlier point about building the relationships. I think for a lot of people, you know, if you think younger people who perhaps see a GP once every 5-10 years or something, what does a relationship mean there? They know the service is available versus perhaps someone who's got long-term conditions, they're older, and they have different needs. And I think that's one of the things that will change people's perception of the term, because if I'm 20 something, I'm fairly, fit and healthy, I just need to get something checked out, versus someone who perhaps has got more issues that they want to deal with, and they perhaps need more of that trust and confidence in the service. I think there is that whole issue about, what is a relationship, and it gets into that slightly dodgy territory perhaps for some in terms of it's too close. But I think, as you said in your opening comment, Martin, perhaps it's more about relationship-based medicine rather than the care they receive.
Okay, that's great. Gwen, from your perspective, good term, comprehensible term?
Yeah, I think it's actually really crucial because it is about the relationship that you have then and there, and I think for patients to know that doctors are there for them is really important, so that we're there when they need them, as well as present when they're actually with us.
Yeah. Okay, great. So so let's look at where relationships add value and where they might not do. Moen, any kind of practical examples of where you think relationships are important?
Yeah, I think relationships are really important. They're key to anything, really. I think having a good relationship, you're more likely to have a good, open, frank discussion, really get to the root cause of an issue. I think quite often, if you don't have a good relationship, you might have a closed consultation. You may not get to the root cause of what the problem is, and therefore you may then give not the correct or the appropriate result or outcome. And therefore then the patient will then come back, a few weeks later with the same problem, and then we sort of go around in circles. So I think relationships are really, really key. I think we need to move away from that transactional medical model and move it more towards that holistic, person-centered, what matters to you, as opposed to what's the matter with you. I did want to add one other thing, if I may. It's more about sort of addressing sort of health inequalities. We know that healthcare plays about 10% of population health, and therefore we want to try and move away from that medicine is the answer, and actually the 90% of health, which is that holistic, the community, the other bits which we need to explore. And in general practice, we're quite privileged to have that time and space to be able to do that over years. And I think what's key to that ingredient is the relationship. So without that we wouldn't be able to get all that information over years, which, even though it's a 10-minute consultation, over a few years, that becomes hours and weeks and months. So really is paramount to how we can support our individuals, identifying the assets which build in our community, and even in our individuals. We always find what's wrong with you, actually what's good about you, what can we do to bring that, what you enjoy doing out of you, and what can get you to your journey. So really sort of person-centered health coaching, getting them to to that place. They won't do that if you've got a bad relationship. So you really need to make sure that that's the number one priority.
Okay, so what do you say to doctors who say, I understand that kind of 90-10, 10%, only 10% of problems are amenable to action by the health service, but I've been trained to operate in that 10%. Why are you trying to get me into an area where I've not been trained to operate? How do you respond to those people?
Yeah, no, really good question. I think that's I think that's part of one of the challenges we face. GPs are very busy up and down the country firefighting lots of things, and they haven't got the time to sort of think of new ways of working. And that does sound patronising, but it's not. It's actually, what as individuals do we need? We enjoy things we like doing, and in order to get there, we need to build a path, not by giving them a medical route. And so it's showing the evidence. I think the advocacy from the Royal College, having webinars like this where we can discuss it, so our peers can actually really see and understand. Actually, all right, that's what that's how I can get the support I need. If we give the wrong care, we'll get the wrong answer. They'll come back. I think it starts at GP training as well. GP registrars, we need to start educating them. Myself and Gwyn have talked about this for over a number of times about if we can get the education there about what's important, about what matters to an individual, then I think that sets you on the right trajectory. I've been GP for 12 years now, and there was a time where I was sort of starting to burn out because I was just firefighting, but now I'm involved in person-centered care and actually seeing some real benefits and impactful stuff, which has allowed me to sort of manage my workload and actually give the better solutions to my patients. And it's not been because I'm an academic or I know the latest guidelines, because it's far from it. I know where to look for them, but I've actually listened to my patients and actually, look, you need some of this, we need some social prescribing, we need to get some exercise, or you need to think about a new workplace. And that's not in textbooks. That's the relationship you're having with the patient in front of you.
So you're saying that a focus on relationships has given you greater professional satisfaction? Is that what you're saying?
Yeah, it's helping with workforce. Workforce is an issue at the moment, and I think we are burning out because we're just doing more of the same. Let's try and support them, not with just more money, but actually this is how we can develop that with our extended role. So we've got social prescribers, paramedics. We can get them to help support us with some of the medical roles, and for ourselves, we can really use that relationship with the patient who trusts the GPs. 95% of patients trust GPs, 10% for policymakers and MPs and journalists, etc., etc. So we're a real advocate for a lot of patients, and I think a lot of GPs don't realise how much we are sort of say can really help an individual get to where they need to get to, and a little bit of endorsement, a little bit of encouragement can really do wonders.
Brilliant, thank you. So Graham, do you think this differentiation between transactional care and relational care is a helpful differentiation?
I think so. I mean, I think what transactional care ignores is the huge therapeutic potential that exists between a healthcare professional and their patient, and the relationship of that between them. And so, I mean, we know that as you mentioned in your introduction, that we can sort of boost the beneficial outcomes for patients just by maximizing the therapeutic relationship. And if we just retreat to a transactional type approach, we'll be quite disappointed with the outcomes. They'll be much limited and much less than we expected.
Yeah. Okay. So great. Sorry. Yes, Owen, please.
Yeah, I was just going to follow that up, because I think there is something about, you've talked about the ability to build trust quite quickly in that sort of transactional relationship. And again, if I come back to younger people who don't have much contact, it's about building that up, isn't it? Because the positive experience that comes out of the sprained ankle, the red eye, whatever, then starts to build up that concept of trust, doesn't it? Even if you're not seeing a GP regularly, you start to build that feeling of comfort and security of seeing someone. And I think for me, that's where I saw some of that challenge, is that it's those who make little use of general practice at the moment, but who may need to in the future. And I suppose that's something that we need to think about in terms of, it's almost an inequality, isn't it? They're not necessarily picking up all the screening services, the public health messages that you might want to deliver at that point, and it's harder to do just in transactional care. But it's about how we build up from that first contact that you have for that acute issue.
And therein lies one of the challenges, doesn't it? Because it's very popular for some people to talk about GPs should be, well, all professionals should be operating at the top of their license, which I guess the suggestion is that means you shouldn't be doing pill checks or checking blood pressure or looking at sore throats. And yet you're saying, Owen, that those are opportunities to build a relationship. And if we lose them at our peril, is that what you're saying?
No, no, I don't think I am, because I think those cases will come in. And I know we'll probably touch on digital consultations later, but I think, you know, there is something about, there will still be some of that transactional stuff which will come to a practice. I suppose where it then starts to spill out, and it plays to some of what Mo was saying, in terms of where you then have a wider primary care team of other clinicians and non-clinicians all looking at a patient or an individual. And in that situation, who is that main relationship with? Is it with someone from Breathe Easy, if you've got, you know, COPD, or actually is it a clinician within the primary care team?
Yeah, good.
Yeah, thanks. I was thinking about the getting to the nub of the consultation and how crucial it is to build a relationship to get there. And often, in a difficult consultation, often it's because we've not been able to build that relationship to the point where the patient trusts us to be able to tell us what the actual issue is. The other thing I was thinking about was how this is about complexity of care sometimes too, in that there are wider determinants of health that often patients may not feel empowered enough, or they might be a bit shy to tell us that things are not going well in their lives. So I think it's really important as professionals how we think about giving patients the permission to understand the consultations about them, and it's about supporting them to get the healthcare that they need, or to address the problems that are going on in their lives.
That's really helpful, and it leads nicely to my next question, which is probably more of a challenge actually for all of you. So you've nicely described the importance of relationship-based care. I suppose my question is, how deliverable is it in the current environment? And let's talk about pre-COVID. I know a lot of GPs were saying that they were working at 130% of what they should have been working, 130% of what they felt was safe, and they simply didn't have time to deliver the quality of care that they wanted to. And as a consequence of COVID, where workload at least temporarily went down, we saw some really interesting data from routine data that we collect in the college, which suggested that prior to the COVID crisis, 24% of GPs said that they felt able to deliver the quality of care they wanted to deliver. But whilst the workload was down, that had gone up to nearly 40%. Still not good enough, but people were creating space in order to deliver high quality care. So my question to you, I guess, is relationship-based care a bit of a pipe dream? Is it about nostalgia? Is it really deliverable in the current environment? Graham.
Thank you for giving me that question first, because this is a really, really good question and a really difficult one to answer. I mean, I think despite everything that's going on, and you know, the fundamental basis within relationship with our patients is boosting the human factors that improve the quality of the conversation and then improve the quality of outcomes. And of course, there's lots of things that get in the way of that. You know, our own well-being, and if we're burnt out and demoralized, or in fact, if we become dehumanized by work that is you know, mechanistic and soulless, it really has an effect on us. But I still think we still have these precious encounters with patients, and we can still maximize those opportunities. And as Mohan said, you know, his sort of cure for burnout and business and things like that is, you know, is refocusing his attention on that consultation and that connection with the patient, and that boosts his own well-being. And you know, and that really implies the mutual benefits that we get from relationship-based care. It not only benefits the patient, but it also benefits us, and that's really important and gives us satisfaction. So I think we can, and I think one of the interesting things about COVID is it's actually shine a light on some of the soulless mechanistic work, the bureaucratic stuff that we've temporarily been able to drop. And I think it's allowed us to say, well, actually, do we really need to pick all of this up again when post-COVID? And hopefully that will create space to reconnect ourselves with our humanizing work. I mean, I do worry that the continuity is being fragmented, and perhaps one of the threats, as we said, is the multidisciplinary team nature. So we might be less involved with many of our patients, and I think we need to find a way of preserving that. And some of the ways that I think really do humanize us, if you like, some of the work aspects that really humanize us are perhaps our palliative care work, our home visiting work. And I think we've got to make sure that we hold on to that, because that really is the things that really sort of boost our humanity and improve our ability to practice in this relationship-based way.
Okay, that's really interesting. I think we'll come back to that. Jen.
Yes, I mean, you asked if relationship-based care is sort of possible in this time, and I think it is absolutely essential. Actually, I think it's the only way that we can really move forward in a way that meets our real purpose of what general practice does. In my research, I studied really some of the long-standing problems of access within general practice, which I call it a paradox, in which this demand on general practice, which we all feel with that workload, and some of the rigid rules that have come across to try to control that demand, along with that undermining of continuity that I mentioned from various policies, that has really led to actually a lot of the unnecessary work. Particularly as an outsider, I saw a lot of unnecessary work on the part of the receptionist, telling people to call again tomorrow because they're still doing same day scheduling, and people continually, patients asking for continuity, but that was the thing that was most unable to be accommodated for in the various systems. And I worked in much larger practices in the States than I have here. I trained in a practice of 30,000 patients, and we had lots of mechanisms in place to preserve continuity even at such a large scale. So I've been quite surprised by the way that continuity sort of hasn't been preserved within general practice for various reasons in this country. But I think that in terms of what we have to do going forward, restoring continuity to the extent that we can as a priority. And I know you mentioned that people might be working part-time, et cetera, but it doesn't take that much. You said we can establish a rapport within one individual interaction. I'm sort of thinking of this concept of opportunistic continuity. One chance to meet someone, make that relationship, tell them I'm another doctor here that knows you now, and you're welcome to come to me with anything else. We often talk about young people and the things they come for, and that people say, oh, continuity might not matter for this or that, but I see every opportunity with a patient as a chance to build that continuity and to build that level of trust and to extend that to the whole practice, because we say, we're all here for you and that, but now you know me. I have one anecdote of a patient. I happen to live in the area near where I work, so I happened to see a young teenager on a train one morning, clearly after a night out, and she recognized me. I'd seen her once at that point, and in the middle of the friend she was with, she said, "That's my doctor." And it was one of those interactions where you're not quite sure how to respond in the middle of a train, etc. But as I reflected on that, I thought, I'm so glad that she thinks she has a doctor, because she's someone who I would really want to come to me with the several issues that I happen to know she has going on socially, etc. I'm glad she actually thinks there's somebody at that practice that she calls her doctor. So I think even I, who happens to work 2 days a week, there's definitely room for continuity to be preserved for me and my patients. And what I saw in my research is that if we preserve the continuity, we build some bandwidth and capacity to do some of that work that we're saying provides for that satisfaction, taking the extra time, doing some of that outreach work, etc. So that's where the efficiency will actually come in, rather than the reverse, which is often assumed that continuity is more work somehow.
Okay, so I've got a question. I'm not quite sure how to express it. It might be slightly indelicate, but when you were working in your practice in the States, were there incentives to encourage you to deliver continuity of care, or was it just the professional drivers of the people you were working with?
It was sort of just how it was structured. I mean, I'm very surprised in this country. I know that the sort of name GP or certain list that was sort of phased out in policy. People were registered with a practice, not with a doctor. Then they've added that back for the over 75s. In my research, I had focus groups of people saying, well, I have the doctor that I go to, and then I have the one that they sort of assigned me when they did that, and those aren't even the same people. We had lists of people, even as trainees. You know, I was responsible for my kind of list of 300 or so patients. I was in the same practice for 3 years. So I built that continuity over time, that's standard. So, and people were often sort of, sometimes they were shifting between one or the other of us. I often said, oh, you should always have a primary and a secondary in our surgery because it's so big. You know, that way, if you can't see the one who knows you best, you're at least seeing somebody else consistent. And that's just sort of how it was. We've never thought in the States that we should completely do away with sort of a named GP here. And I find people tend to, not in all practices, but in certain practices, almost ignore that field of who the person's GP is. They might have a relationship with somebody in the surgery, but it's often not even, you know, who's listed. And I think that that's a waste of an opportunity to make that field mean something, both for the patient and for the wider team within the practice, so that they know who's actually the person in the building that does know that patient.
That's really helpful. Now we've got 3 people who want to speak, so I'm going to take all 3 of you, and then we've got a question from the audience as well. So it was Owen first, and then Moen, and then Gwyn. Owen.
I just wonder whether the current situation makes relationship-based care even more important. Because, you know, if we think about what we've all read in the press, what's been described within the college about, you know, the number of A&E attendances, number of GP consultations dropping off. And certainly when we talked about this within the group in college, it was 2 things. It was the risk of infection of going to the GP and picking up something in the waiting room. But there was also a sense it was, I don't want to bother the doctor because he or she's really busy at the moment. You know, it must be hell being a GP. And we then talk about all those misdiagnoses or, you know, conditions which have worsened when perhaps we could have intervened soon. And part of me thinks actually it makes it all the more important, doesn't it? Because if this is not going to go away, we're going to get more spikes, whatever, then actually being able to build up that more of that relationship and trust means that hopefully patients will be going more regularly, they'll be going at the right time in their pathway to seek the help that they might need.
That's really helpful. I agree. Moen.
Yeah, I completely echo what Owen and Jen were saying. So it's really important now for that relationship-based care to look around and see what relationships are possible. We need to co-produce, collaborate, and identify what really matters to an individual. I think with the evolution of primary care networks, we've got a population size of 30 to 50,000, which gives us nice critical mass to then deliver services which can support certain cohorts. And actually, if we get person-centered care correct, and we get it right, and we get to the root cause of an issue, it means that actually that individual won't repeatedly come back and see their GP because they've had unfinished business. So allowing time for the GP to spend time with that individual, utilize their allocated allied healthcare professionals to support an individual will give them the better care they need. And I reflect back on my own experience. I talked to earlier about burnout, and you know, I work in a deprived part of Merton. And I was hitting my head against a big wall, not being able to help some of these patients who are coming and seeing me. But now the link worker is able to really connect with them and identify things which can relate to them and support the care they need. I don't see some of these patients anymore. Not that the relationship's lost, but it means they're getting what they want. And I see them a bit like Jen's story. I see them working in the cafe down the road, working in the local community centre, being volunteers. And actually I see them being embedded in the community and actually adding to resilience. And actually they stop being a peripheral member of the community and start being central. So I think you can then start seeing how the ripple-on effect of that one-to-one interaction with the GP and their patient can have such huge benefits in the community and build resilience. So I truly echo that it's really important, even more now during COVID times. And our communities have come together, to be fair. We've seen volunteers come out of nowhere. The NHS volunteer scheme has really helped support our communities as other support workers. So yeah, I just really echo those facts.
That's brilliant. So more important, but I suppose the question is is it less deliverable? And I'm interested in Jen's story, in which she said, well, it was just the right thing to do professionally, and we got on and did it. And I'm a bit inclined, I think, to blame other people like policymakers for making general practice too busy, for not having enough doctors, for whatever. And I'm not sure whether that's fair or not. So maybe we'll come back to that a little later. Gwyn, sorry.
Yeah, the point I was going to make was how patients get to know the different doctors in the practice. And even though we might not be there all the time, they know or they hear and choose what type of doctor they want to see for which type of problem. And I think relationships are built one person at a time, one relationship at a time. And I see quite a few mental health patients who may be quite complex. And my personal experience is that somebody might need you, or might need that continuity a lot at the beginning of their care. But as they start to improve, they sort of feel more empowered, and they know that you're there for them, so they need you less and less, but then that, like you've all said, the relationship has been built then, and they know, even though they might not see you for a long time, that you'll still be there, and you'll be there for them. The second thing I was going to say was about how, relating to Mohan's point, the relationships with our team as well, and recognizing as GPs, we don't have to do it all now. We've got a team, we've got teams around us, and everybody's got their own strengths, and there can be relationships built within our team so that we recognize those who can help with what. So that will help with sustainability going forwards for general practice.
Yeah. Brilliant. Thank you very much. A really, really good point. So we've got a question from Emma in Northern Ireland. And Emma says, my question would be, how can we enhance, upskill our phone and video consultation skills to maintain relationships and relationship-based care? So this takes us to the very relevant question at the moment. During the COVID era, we've shifted, well, pre-COVID, 75% of consultations were delivered face-to-face. At the height of the COVID crisis, that was down to about 10%. Now it's back up to about 30%. We don't know where it's going to reach an equilibrium, but we do know that remote consultations are going to be much more common in the future. So the question is, how do we deliver that? And she added, I like the move that we've made to this style of consultation, remote consulting, and having physical contact only with those that really need it, such as chronic diseases, palliative care, needing assessment in person. Who'd like to address that one? Go on, Jen, yes.
I thought I would take the opportunity to point out how what we've said so far does resonate with the changes that have happened so far in the pandemic, which is that we've shifted largely to remote consultations as sort of the default, when before the default was face-to-face. And that's true in both healthcare systems. The US hadn't previously sorted out telephone billing so well, so we were also doing face-to-face, so there's no sort of difference there. But I think there's a lot of hidden work in the way things were previously done, and a lot of that hidden work is on behalf of the patients, both the way that they had to call to get into our systems to even ask for an appointment, the work of coming to the surgery, lots of travel. Some people who have physical disabilities, that travel could even be painful. It would take a long time. And then a lot of work I saw around the way repeat prescriptions are done, et cetera. And I think there's a lot that can be improved in terms of what I mentioned as kind of optimizing access. In my opinion, is optimizing that fit between the patient side and the healthcare service side. And I think what this has shown is that a telephone consultation or a video consultation is sometimes the better fit for both of those sides, particularly if it's already built on a relationship. And I think we need to remember that leading into this pandemic, we were seeing everybody face-to-face. So those encounters to build those relationships were face-to-face encounters. And I think that's important for building rapport. And we won't know what this will look like if that's not the norm for a while. but I think with less work on both parts, the remote consultations do allow for a slightly better fit that meets the needs of both sides with a bit less work. So the patient doesn't have to travel, they don't have to wait in a waiting room. We have a little bit more flexibility. The person's not waiting in the waiting room, so if something else that's important comes up, we can sort of deal with it. We can take that bit longer on the phone with certain patients because we don't sort of have that pressure, that social pressure of the waiting room full of people and us sort of always chronically running behind. We've sort of done away with some of that. So it's given us that chance to do that. And I just spoke on the phone with someone yesterday who has a chronic condition that can be quite debilitating. And I've not actually met her in person. I came across her for the first time during the pandemic. I think it was our third consultation. She said, I really like these on the phone because I think she feels that when she thinks of something, she's able to bring it up and you know, we take the time to address it. And she has you know, many aspects of her needs in terms of chronic pain and issues in terms of her home setting. And even without seeing her, we've been able to address that. And I think for her to have come in all of those times, to then have me cut the consultation short because I was running behind and there was so many people waiting for me in the waiting room, it often is what leads to that sort of dissatisfaction between both patient and provider. And what we've been able to do in these slightly different ways during the pandemic has sort of solved some of those problems. So that's what I think we need to preserve going forward. But then balancing that with realizing that it's easier to recognize someone as a person if you are seeing them in person, and that we can't do away with that completely.
Yeah. Okay. So remote relationships maybe are easier if you have a pre-existing physical relationship with somebody, but if you don't, what does a digital relationship look like? Is it different? What are relationships that teenagers have on social media? Are they substantive kind of healing therapeutic relationships or not? Mohan?
Yeah, I was going to pick up on that. So I think the relationship of digitals is fascinating, isn't it? I mean, the statistic you just said, we've all moved into that realm, whether we like it or not. And, you know, 4 months ago, we would have all said, I'm not doing that, I'm not ready for it, X, Y, and Z. So we've kind of got into that position. And actually, there's lots and lots of benefits for patients. It's opened up access, as Jen was saying, people get online prescriptions, online queries. You can actually answer queries online, video consulting, telephone. There's opened up a lot of access for certain cohorts, which has then improved their access. Now, on the flip side, there's also those patients who, you know, aren't digitally advanced or digitally phobic, that then closes an access for them. But then for them, we need to cater for the old style of model. Actually, we need to be able to cater for them. But I think for the digital relationship, it's improved access to a certain cohort who actually have found some great benefit from it, who are able to make it work for them, be able to do it at work, do it in the comfort of their home, be at home, relax in the comfort of the home, and actually talk a bit more about what matters to them rather than talk through the barriers. Jen talked about call for an appointment, then get to the appointment, then wait in the waiting room, and then start getting anxious. It's actually, you know, beneficial to them. But it needs to be tossed up with those who actually see it as a barrier. But I think in terms of skills, I think that's educating to the clinicians about how to approach it. Some of the resources we can send patients after the consultation, they often forget what's been told in the consultation, but you can follow it up with an email through Accurix was one of them about their condition, so they can get more information about it afterwards. And so it is a new age, but I think we need to make sure we don't leave behind those who aren't ready to move on.
Yeah, really helpful. Graham. Sorry, you're muted, Graham. You're the first person. Well done.
Yeah, sorry. I was pressing the space bar and I wasn't unmuting. I think my computer had gone to sleep. Yeah, so it's interesting skills. I mean, it's a whole new skill set often for our patients as well. It's very difficult for them to get used to. Some people aren't so good on the telephone, and hearing problems and all these communication difficulties are magnified. But what we're doing around people with long-term conditions, particularly, is giving them preparation before we do a telephone review. So we're sending the traditional sort of prompt sheets that we send people, inviting them to think about the things they might want to discuss. We've added a few more relevant to COVID, about what their worries are about COVID, where they would go to help, giving them the offer to discuss more sort of anticipatory care planning issues, advanced planning. And that's worked really well. They're given a time slot. We instruct them to, it's going to take 20 minutes. I think to do it well, it does need time. You don't want to rush a telephone call. And making sure that that they're sitting down, have a pen and paper ready, could be really, really helpful. And it's important because we're not cold calling them for these reviews, which I think there was caused a lot of distress and dilemma when we sort of started to raise more sensitive issues, and we've given them invitation to talk about these beforehand. If they don't want to bring them up, that's absolutely fine. So that's been a real core skill for us. But I'd like to say, actually, what's really shifted is face-to-face conversations have become really difficult, because we're not face-to-face, we're mask to mask, and that's really sort of filtering out a lot of the nuance of non-verbal communication. So, for many of these things, actually, a video consultation is actually really advantageous, because we can actually see each other, which is really helpful.
Gosh, yes, really, really interesting. If there's more questions to come in, please do send them in from the audience. Owen, I think you wanted to contribute.
Well, I'm just very quickly, I think my thunder's been stolen by Mo and Graham, because I think some of the concerns are very much around that inequality in digital health literacy, and those groups who can't access for a vast number of reasons. And again, it's about making sure that they can still access something. And I think Graham's point as well about, it's not just skilling up clinicians to do this, it's also helping patients to prepare properly for it. And we've seen this week a report from Health Watch England, The Doctor Will Zoom You Now, which has got some of those hints for patients in terms of, actually, this is how to prepare, what to think about, where to sit. And I suppose the final point as well is also about some of the safeguarding issues in digital consultation, where you don't necessarily know whether there is a perpetrator in the house, and therefore that limits some of the conversation that you might want to have with the patient.
Yeah. What did you think of that, the Doctor Will Zoom You Now report? Because it was quite, in parts, it was very helpful. In parts, it was quite critical of where general practice is at the moment in terms of what it's delivering.
Yeah, I mean, declaring an interest as someone who runs a health watch, it's often quite difficult to get the true picture. And I think I challenged you, Martin, in terms of saying, well, actually, are people accepting digital consultations now because it's probably the only game in town? And if we didn't have this, would there be that same level of take-up and acceptance of them? And I suppose it's like any piece of research, isn't it? That you'll get those people who want to respond to surveys and engagement events. But again, if I were to ask, was this really reflective of the communities in which we all live? Like Thameside, like Leeds, like parts of Merton, actually you might get some very different views there. So I think we've got to be really careful that there is no one patient, and you know that better than I do, and therefore we have to try and look for the good in the report as well.
Yeah, that's really helpful. Those who are interested in the audience, it's National Voices. If you go onto their website, and it's called The Patient Will Zoom. Is it? The Doctor Will Zoom You Now. Is it?
Yeah.
I've forgotten the name of it. The Doctor Will Zoom You Now. There you go. Just before I bring Gwyn in, we've got a message from Amanda Howe, who happens to be the college president and is here this evening, which is wonderful. So she's added, maybe the message is every consultation needs to be person-centered, and then we need to assess the need for continuity with the patients. Some only need it short-term, some don't need it at all, but the system should be capable of allowing us to give it where it's needed. So we should be designing continuity in rather than designing it out, which sometimes it does feel like that's where we are. Okay, Gwyn. Thank you, Amanda. I agree entirely. Gwyn.
Yeah, so the point I was going to make was about what type of relationships society have now. And a lot of relationships now are more virtual. And I think that what we can do is respond to the different needs of our different types of populations so that we don't widen any inequalities in access. So in my surgery where I am now, we have some very young people, but we have some older people. Is that there's a real mixed population, and some people do prefer to telephone, some people do prefer to do e-consult. People like the convenience of a video or a telephone call, so they don't have to take time off work. But then there are people who will still come into the surgery to try and book an appointment, and I think we just need to be flexible in our approach, and like you say, sort of just design it in and work with whatever comes our way, really.
Yeah. No,
Thanks.
exactly right. Okay, I'm going to ask you all a question shortly, and I'm going to give you forewarning of it. So this is the elevator pitch. So you find yourself in a lift with the Secretary of State. You've got 30 seconds to tell the Secretary of State why relationships matter. Okay, so you can have a think about that and see what you think. It would be interesting to see. Before we do that, I just want to come back to something we touched on earlier, which is training for relationship-based medicine. How good is the training that medical students and specialist GP trainees get at the moment? How does it compare with what they might have got 5 or 10 years ago? And what does training for relationship-based care actually look like? Gwyn, you've been quite involved in this, I think, haven't you?
Yeah,
sorry, I've interrupted you working out your answer to my previous question. That was nasty of me, wasn't it? Carry on.
It's okay. I've recently qualified as a coach, and a lot of my thinking has been about how we can. When you're coaching, it is about making the conversation completely about the person in front of you. So there's a lot of parallels in communication skills training and consultation skills there. And also helping somebody set goals and work through challenges. So I think for complex care and the health coaching approach, there's something that resonates there. Regarding training, obviously all GP trainees get trained up in communication skills, consultation skills, and I think that's what sets us apart as GPs, because we are able to have that sort of deeper conversation with the patient and make the agenda about them. But I think thinking about the future and that health coaching approach, how many of us as GPs have experienced coaching ourselves or had that sort of investment in the leadership development side of our character in self-awareness? So I'll just throw that out to the floor.
Does anyone else do health coaching?
Sort of our modus operandi with our care and support planning is a sort of a blend of health coaching, motivational interviewing, but really focusing on sort of goal setting and action planning, very much key to it, and particularly the sort of cohort that we're targeting is the practice nurses, because they do the bulk of these long-term condition reviews, and it is a real challenge because they have been, hardwired in the sort of transactional approach with hardwired to the processes of care, and it's a whole new skill set, and it's right, we have to take them right back to sort of values. It's really, really important, right back to themselves, of what they want to get out of their relationships with patients, and so it is quite challenging. We've tried actually to sort of do this with undergraduates, so medical students, and that's quite difficult, and also GP trainees, so it's still quite difficult, and I think that's just where they are in their evolution and maturity and development. We seem to have better success with established practitioners who have been sort of got the old way of working and feeling quite uncomfortable with it and want to change, and they seem really to get it and motivated.
Okay, that's interesting. Mohan, you were nodding there. Is that your experience too?
Yeah, I was just going to add, I think for trainees, I think you really want to highlight the importance of relationship-based care. But I think seeing is believing, and in the first 3 or 4 years when I qualified, I think you then start realizing, God, it is being a relationship. Time is really a diagnostic cure, and actually having that time, bringing them back in, following them up, you can then really see how that makes a difference. I think with trainees, they have attachment for 3 months, 6 months, 12 months, and so they may not have enough time to build the relationships. And so when we tell them how important it is, it's quite tricky for them to kind of really internalize it. But I think I echo what Amanda mentioned on the post, that actually person-centered care, actually, we can start off with that as the initial starting point, the priority. Look, what really matters to you? Let's start there. Let's build on that next time we see you, and then the time we see you after that. And before you know it, you've then built a relationship. But I think it's quite hard to then really develop that as a training need when the time is quite short. But certainly an important part.
So are trainees prepared for the fact that practice gets better and better the more experienced you become? Is that something that we say to our trainees?
I think we sort of mentioned that. Well, I tell my trainees that, you know, with you pick up a lot more subtle signs, and you've picked up a whole breadth of knowledge about their relationship with their partner, their kids, their job, and that's something which is adds to your bank of that particular individual, and that can only enhance your understanding of what matters to them, and actually where they are in their particular point in time. So I think that's a really valuable tool which only time can develop. So I think we can certainly tell them and enhance that, but I think once they see it, they can then really truly integrate it.
Okay, brilliant. Now, I know there's others of you who want to speak, but we've only got a few minutes left, so I want to come back to this elevator pitch question. So you find yourself very happily in a lift with Matt Hancock, and you've got 30 seconds to persuade him that relationship-based care is really important. Who's brave enough to go first? Jen, you're brave enough to go first. Well done. Here we go. I'm Matt Hancock, okay?
Hello, sir. So when I observe in general practice, what I found time and again, both when I sat with reception, especially when I sat with the receptionist dealing with patient requests, is that it dawned on me that the healthcare service is essentially people. We think of it as buildings and maybe some of the technology and things like that. But what people are trying to get to is a person who can help them, either through a face-to-face consultation or some information passed to them. And those people can be the clinicians in the team, and they often can also be the receptionists on the team. They use their knowledge of these patients to know the patients within the practice. They know them very well. The receptionists within practices often have been there a very long time and know the population. And it's their knowledge and their skills that need to be able to be flexed, to be able to be used in the best way. If access is essentially the interaction between two people, we need to create the healthcare system that can allow those people to use all of their skills. And what I was observing, unfortunately, was
you're on the 4th floor.
Oh, people complaining that GPs couldn't listen, and receptionists also often couldn't flex the rules to help meet patients' individual needs. So I think it's great to give consultation skills, but we need to give an environment and a length of time for people to be able to listen and respond, and for receptionists to be able to give person-centered care too.
Brilliant. Very good. A very good case. Gwyn.
Oh gosh. Hello, sir. When you go to see your doctor, what are you hoping for? What would matter the most to you? Do you think that being truly heard and having your concerns addressed in an appointment of an appropriate length is more valuable than having to book numerous appointments to come back and get those concerns addressed?
Very good. Okay. Thank you very much. Mohan.
So I say hello, and I'd say relationship-based care is the underpinning of what general practice is about. It's what the ingredient is, what develops the outcomes. We utilise our other tools to support an individual's journey, but it's that relationship which we need to build, and I think we can focus some time on extending that. And I'll give an example. Just from during COVID time, we've now found time to have coffee with each other, coffee break during mid-morning break, which we've not had before, and that has really improved the workings of our practice. And so the relationship really is key. So we need to focus on that along with person-centered care.
Tremendous. Thank you, Mohan. Graham. You can talk to the Scottish Secretary of State for Health if you prefer.
I think the main thing is, please can you be aware of the costs, both in that is caused by bad medicine when we have poor relational care. So that would be the worst thing, the first thing, and I think those costs will be huge when you take into sort of litigation and North staffs and all these sort of things that resulted from poor relational care. So that would be my main question, and yeah, there was a second one, but I think we're on the third floor. So yeah.
Great, that's brilliant. Thank you very much. And last but in no means least, the patient voice, Owen.
Thank you. Well, Secretary of State, I think it's really important that we work collectively around relationship-based medicine. For me, it gives me better outcomes. It addresses my needs, not my wants, but my needs. And I think if we can get that right, we'll have happy patients. Happy patients equals happy GPs. Happy GPs equals a happy NHS. A happy NHS means a happy Secretary of State and Chancellor.
Brilliant. Do you know what? I'm thoroughly persuaded by all five of them. So, so thank you very much indeed. We've reached time, and that's been a really great session. Thank you for your contributions. It's been brilliant. Thank you so much for the audience. Thank you for the questions that we've received as well. This is the final RCGP Together Live of the summer, so we're going to have a break over August. We'll be reintroducing them in September. Please get in touch with us to let us know what subjects you'd like to address. Have a brilliant summer, and please carry on using RCGP resources, carry on contributing to your college. Thank you so much indeed.